Assalamu alaikum. Today we are going to discuss RCOG Green Top Guidelines number 20A, that is external cephalic version to reduce the incidence of term breech presentation, and Green Top Guideline number 20B, which discusses about vaginal breech delivery. So external cephalic version, we all know, means manual manipulation of the fetus through the maternal abdomen, aiming to achieve cephalic presentation. Primary goal is to reduce non-cephalic birth and reduce cesarean section rate, thereby reducing maternal morbidity resulting from a C-section. Breech at term normally presents in about 3 to 4% of the cases. It is more common in nullipara and preterm gestation. After term breech drive, a sharp decline in vaginal breech birth has been observed, so as to prevent breech at term is critical, both to reduce maternal as well as to reduce fetal morbidity. External cephalic version. So effectiveness of external cephalic version, success rates of ECV is approximately 50%. Overall success rate is 47 to 50% at birth, with the success rate being 60% in multis and 40% in Nelly, and average success rate being 50%. Few turn spontaneously after failed external cephalic version after 36 weeks of gestation. So this statement means we did ECV, but it was not successful. However, the baby spontaneously aborted in about 3 to 7% of the cases after a failed attempt of ECV. In priming gravid after 36 weeks, about 8% revert to cephalic even without an ECV. Few revert to breech after successful ECV. Similarly, we did a successful ECV, but the baby reverted to breech. This occurs in about 3% of the cases. Successful ECV reduces cesarean section rate. Cesarean section rate is reduced. Relative risk is 0.57, and relative risk reduction is 43% versus no ECV done. Absolute cesarean section reduction varies by population. So overall, we can say that there is a relative risk reduction in total cesarean rates by 0.57 RR. ECV at term has an overall success rate of about 50%, and after an unsuccessful ECV at more than 36 weeks, only 3 to 7% of fetuses will spontaneously turn cephalic. Reversion to breech after a successful ECV is rare, occurring in approximately 3% of the cases. Attempting ECV at term reduces the risk of cesarean section with a relative risk of about 0.7%. Meta-analysis shows that non-cephalic birth rate is reduced by ECV by a relative risk of 0.42, and cesarean section rate is reduced by ECV by RR of 0.57, and labor outcomes after successful ECV. So if outcome is a cesarean section, we can see that slightly increase risk of cesarean section versus spontaneous cephalic, because when we do manipulation, there's a slightly enhanced risk of cesarean section. Instrumental delivery is slightly increased compared to spontaneous natural cephalic. Mechanism: obstructed labor. Odds ratio is 2.2, so the rate is increased, and increased risk of fetal distress in ECV. ECV odds ratio is 2.2. Successful ECV does not normalize labor risk to baseline. Predictors of successful ECV. So we are going to introduce a mnemonic to memorize the predictors of successful ECV, and remember that if these predictors are not there, it does not mean that we cannot attempt an ECV. These are not contraindication, these are only predictors of successful ECV. The mnemonic is flip them back. You can remember it as flip them back, flip the babies back, which are breech. So who is most likely to flip and not get back to breech? Flip. F for fluid. The fluid has to be AFI should be more than 10 to lead to an odds ratio success of 1.8. That means good liker. L, loose breech. That is not finished. Odds ratio of success is 9.4. It means a high floating breech is more likely to turn cephalic upon ECV. Then intact posterior placenta, odds ratio of success is 1.9. P is for palpable fetal head. Odds ratio success rate is 6.3. When head is easy to grasp, ECV becomes more appropriate. So FLIP stands for fluid, loosely engaged breech, intact posterior placenta, and P is for palpable fetal head. Now M stands for multiparity, odds ratio success is 2.5, and then back stands for B, the breech attitude. It should be complete breech, not frank. And A stands for added tocolysis, that is the strongest modifiable factor. Then C stands for compact mum, that means a slim smart mum with a normal, rather a lower maternal BMI and weight less than 65. And K stands for keep trying. These models are not for contraindication. And also K also reminds us, do not continue attempting more than 4 times in 10 minutes. So success is more likely if the breech is loose, head is palpable, there is good lighter volume, posterior placenta, multiparity, complete breech, low maternal weight, and if beta mimetic tocolysis has been used. The prediction models should not be used as a contraindication. So beta mimetics improve the success rate of external cephalic version, and the benefits include increased cephalic presentation in labor and decreased cesarean section rate consequent upon successful ECV. The following tocolysis are not recommended: nifedipine, atoxipon, and GTN, which is glycerol trinitrate. It is considered inferior to terbutaline. Let's add just glycerol trinitrate over here. Okay. So practical regime that we should be using while performing ECV is IV salbutamol 250 micrograms in 25 ml of normal saline given slow IV, and subcutaneous terbutaline 250 micrograms. Contraindications to beta mimetics include cardiac disease, hypertension, and beta blockers. That means if a patient is placed on beta blockers for any medical indication, we should not be using beta mimetics in such a case. Analgesia is not routinely recommended, and consider if repeat attempt is required or there is intolerance to pain of manipulation. And analgesia may reduce force required, improve success with tocolysis, and it does not clearly reduce the cesarean section rate. So what should be the timing of ECV? In all women, we should offer ECV at 37 or more weeks of gestation. However, in nulliparity, we can offer it a bit earlier at 36 weeks or earlier. Why not earlier? Because preterm birth, it increases if ECV is done at less than 36 weeks, and cesarean section rate would not be significantly benefited if an earlier ECV is done. Intrapartum special situation. Intrapartum ECV is done only if membranes are intact, informed consent has been taken, and there are no contraindications. Unstable lie plus induction. ECV during stabilizing induction is possible, but risks include quad prolapse and fetal heart rate mobilization. So remember that stabilizing induction means that we have induced on a cephalic presentation to ensure successful vaginal birth. It's not the same as inducing a breech, which is contraindicated. So what are the contraindications to ECV? These are all the situations in which we would normally perform an elective cesarean section otherwise. Absolute contraindications are placenta previa major, placenta abruption, abnormal CTG, severe preeclampsia, ruptured membranes. Absolute indications for cesarean section. Relative caution or cautionary indications to ECV include oligohydramnios, hypertension, multiple pregnancy except after first twin, recent vaginal bleeding and RH, isoimmunization, previous cesarean. One prior cesarean section is not a contraindication. However, high risk consent must be obtained, and there is no increased complication rates shown, and no uterine rupture reports have been seen in studies. What are the risks of ECV? Very low complication risk, and serious complication risk is rare. Emergency cesarean section within 24 hours is 0.5%. Placental abruption is extremely rare, and perinatal death shows no increase. Fetal-maternal hemorrhage can occur in 2.4% of the cases and 30 ml in rare cases. So fetal-maternal hemorrhage may occur even if the procedure is uncomplicated, and NTD is required if performing an ECV in a RH incompatibility disorders. What are the safety measures of doing an ECV? Hospital must have cesarean section facilities should an emergency arise. Pre and post procedure electronic fetal monitoring, that is CTG, should be done. There is no routine fasting or IV line requirement. NTD for RH negative women should be taken. Maximum 4 attempts in 10 minutes are required. Transient bradycardia is common for less than 3 minutes. However, if it persists more than 6 minutes, then it is an indication for category 1 cesarean section. Who should perform an external cephalic version? Only trained practitioners or supervised trainees should be able to do external cephalic version. Midwife can perform if they are properly trained. So what is the acceptability to women? 9% decline ECV, 1/3 report significant pain, and satisfaction is higher if successful. Exam from OSCE point of view must counsel patient about pain and variable tolerance. So what can we do to increase the uptake of ECV? Key barriers include undetected breech. Up to 20 to 30% are missed otherwise, as we know that the guidelines do not recommend routine ultrasound in every visit, and sonography is limited to only mandatory scans. So 20 to 30% of the breaches are missed, and abdominal palpation sensitivity is 70%. So the routine late pregnancy presentation check is category C recommendation, and access to ultrasound after 36 weeks is essential. And recurrence risk, prior breech recurrence is 10%. Large centers may use dedicated ECV clinic. Audit targets include percentage of breech detected antenatally, percentage offered ECV, target is 100%, and success rate should be 50%. Complication rates are need to be measured, and patient experience needs to be recorded. So what are the non-ECV methods? Moxibustion may be considered at 30 to 35 weeks with trained provider, and there is slight increase in cephalic presentation but no consistent increase in rates of cesarean section. Posture management is recommended, but it is not effective alone. I partially disagree with this because we have advised long sajda position with elevated hips to many of our patients, and we have actually seen success in such cases. So what should you do when a patient presents at 36 weeks with breech presentation? We have to confirm presentation with ultrasound. We have to assess contraindications. We have to offer external cephalic version at 37 weeks or more in multi, and at 36 weeks or more if nullipara. And during the procedure, we should give beta mimetics 250 micrograms in 25 minutes IV. Perform ECV with CTG plus ultrasound, and post-procedure CTG is done. If RH negative, we should give NTD whether or not the procedure is successful. So this is an exam trap sheet. External cephalic version, success rate is 80%. We know it's false, it's almost 50%. Failed ECV is usually followed by spontaneous version. It's false, it's not usual, and it is sometimes followed by spontaneous version. Successful ECV normalizes labor risk. That's not true. Beta mimetics improve success of ECV. Yes. Nifedipine is recommended for ECV. No. Prior one cesarean section contraindicates ECV. False. Emergency cesarean after ECV is 5%. False. It's 0.5%. So we have to memorize, keep it in mind. Okay, so routine spinal for ECV is not advisable, and postural exercises are not effective alone. So Overall success rate of external cephalic version is about 50%. Multiparity is a strong predictor of ECV success. Yes. After failed ECV at more than 36 weeks, most breech fetuses turn spontaneously. This is wrong. Spontaneous version occurs only in 3 to 7% of the cases. Reversion to breech after successful ECV is common. False. Reversion is only 3%. Successful ECV significantly reduces cesarean section. It's right. Relative risk reduction is 0.57. Labor after successful ECV carries the same risk as spontaneous cephalic. Labor, no. There is increased risk of cesarean section, odds ratio being 2.2, and instrumental delivery almost 2.2. Prediction models should guide where ECV should be attempted. No, this is a wrong statement. Models lack sufficient predictive value. Low success probability does not mean a reason to avoid an ECV. The breech not engaged is a strongest predictor of ECV success. Among the natural predictors, unengaged breech is the strongest predictor, and among modifiable factors, tocolysis is even the strongest predictor. Use of beta mimetics improves ECV success rate and reduces cesarean section. That's true. Nifedipine is equivalent to beta mimetics for ECV tocolysis. That's wrong. Nifedipine is not recommended usually. Regional anesthesia should be used routinely. No, that's a false statement. ECV should routinely be offered from 34 weeks to prevent breech. It's a false statement. Standard timing for offering ECV is more than 37 weeks. It is true only in all the term pregnancies, but in nullipara, ECV may be offered earlier at 36 weeks or more. Previous one cesarean section is an absolute contraindication to ECV. This is a wrong statement. Placenta previa major is a contraindication to ECV. Yes, it's a true statement. Ruptured membranes are a contraindication to ECV. That's a true statement. Severe preeclampsia is a contraindication to ECV. It's a true statement. Emergency cesarean section within 24 hours of ECV occurs in about 5%. No, it occurs in 0.5%. Placental abruption is a known but very rare complication of ECV. True. Fetal-maternal hemorrhage can occur after ECV. True. NTD is not needed after ECV if procedure is uncomplicated. It's wrong. Pre-procedure fasting and routine IV access are recommended for ECV. Wrong. Transient fetal bradycardia after ECV is common and usually resolves. True. Persistent bradycardia more than 6 minutes after ECV requires category 1 cesarean. It's true. Maximum of 4 attempts or 10 minutes of total manipulation is advised. It's true. ECV should only be performed by trained personnel or supervised trainees. That's true. Most women find ECV painless. That's a wrong statement. Undetected breech at term is a major barrier to ECV uptake. That's true. About 20-30% stays undetected. Abdominal palpation alone is highly sensitive for breech detection. No, it's wrong. Sensitivity 70%. Postural exercises alone are effective for breech. It's wrong as per guideline. Moxibustion at 33 to 35 weeks may increase cephalic presentation. That's true. Intrapartum ECV can be considered if membranes are intact and no contraindication. True. While unstable lie, ECV during stabilizing induction may be considered. That's true. Recurrence risk of breech in next pregnancy is 1 to 2%. That's wrong. Recurrence risk is 10% after one breech delivery. So the first part of the guideline 20A is completed. Thank you very much for being there. Assalamu alaikum.